everyone, and today we are discussing a very interesting topic, that is the segmental approach of imaging evaluation of congenital heart disease. So let's get started. The first investigation is always a frontal chest radiograph, so we'll start with that. First step is always to look for the technical factors and make sure that they are all right. First, we look for the exposure, it is adequate, the inspiratory effort is good, the markers are adequate, the centering and everything is fine. After that, we come to the cardiac part of it. We have to evaluate the situs. So we look for three things. One is the gastric fundic bubble, the aortic knuckle, and also the bronchi. As we know, the right bronchus is always the first one to branch, and aortic knuckle is normally on the left side, gastric fundic bubble is normally on the left side. So this makes it situs solitus. After that, we look for the cardiac position and axis. For cardiac position, what we do is we draw a line in the midline passing through the spinous processes of these vertebral body, and we see that the chunk of the heart is lying more towards the right side of this midline. So we say this is levo position. On the other hand, if the major part of the heart lies on the right side of the chest wall due to any cause, maybe because of even right lung hypoplasia, if the heart is predominantly on the right side, we'll say that it is dextro position. And what about levocardia? Levocardia, it has something to do with the base apex axis of the heart. So we see normally the apex of the heart is pointing down and out towards the left side. So we say it is levocardia. If the apex of the heart is pointing towards the right side, we'll say it is dextrocardia. Why do we need to know all this? Because in cases of situs solitus with isolated dextrocardia or situs inversus with isolated levocardia, the frequency of congenital heart disease is maximum. Around 90 to 95%, and in cases of situs ambiguous where the situs does not fit into the definition of either solitus or inversus, in those cases the frequency of congenital heart disease is almost 100%. So we need to look carefully at the situs and also the axis of the heart. For example, in this case, if you see, the heart is lying more or less in the exactly in the middle of the thoracic cavity. So we say this is a case of mesocardia, and we'll see the CT also of this patient subsequently. This patient had multiple congenital cardiac defects. Next step is to evaluate the size of the heart. For that, we use something called as the cardiothoracic ratio. For the transverse cardiac diameter, what we do, we draw a line in the midline passing through the spinous processes of these vertebral bodies, and we draw a line from the midline to the maximum lateral convexity on the right side, and another line from midline to the maximum convexity on the left side. And we add these two diameters to get the maximum cardiac diameter. And for the thoracic, at the level of the right dome of diaphragm, we draw a line to get the maximum internal thoracic diameter, and we divide these two, multiply by 100 to get the cardiothoracic ratio, which in adults has to be less than 50%, but in neonates it can go up to 60% also normally. After that, we evaluate the normal cardiac contours on a frontal chest radiograph. So the right heart border, if you see, is formed superiorly by the superior vena cava and inferiorly by the right atrium. And on the left side, it is formed superiorly from above downwards by the aortic knuckle, the pulmonary conus, the left atrial appendage or the left auricle, and the left ventricle. And the apex of heart is formed by the left ventricle. So do we have participants here? If I ask you a question, out of the 4 cardiac chambers, which is the one that does not contribute to formation of the normal heart border on a frontal chest radiograph, what will that be? Can you please type your answers in the chat box? I want this to be an interactive session. Which is the one cardiac chamber that does not contribute? I'm getting the answers. Yes. Right auricle, not so much. Right heart border, SVC, right atrium, left heart border, aortic knuckle, pulmonary conus, left atrial appendage and left ventricle. So which is the one that does not contribute to formation of heart border? Right ventricle, yes, that's right. And if we see on the lateral chest radiograph, on the lateral chest radiograph, the anterior border is formed by the right ventricle and posterior border is formed above by the left atrium and below by the left ventricle. So now if I ask you which is that one chamber out of the 4 cardiac chambers that does not contribute to formation of heart border on a lateral chest radiograph, and your answer will be, please type in the chat box. Right atrium, yes. Thank you. Okay, so now that we know which all cardiac chambers contribute to formation of the normal heart contour on the radiograph, we can comment about the individual chamber enlargements. So, starting with the left ventricle, if the cardiothoracic ratio is increased more than 50% in adults, more than 60% in neonates, we look for the apex of the heart. If it is still pointing down and out towards the left side, we say it is LV type of cardiomegaly because of the left ventricle enlargement. And if CT ratio is increased, but the apex of the heart is pointing upwards, we say it is right ventricular enlargement. Then coming to the right atrium, if the convexity of the lower part of the lateral of the right heart border is increased, we say it is because of right atrial enlargement. There are certain measurements also given in the books, and they are, if you measure this distance from the right heart border to the lateral border of the vertebral body, if this is more than 3 centimeters, or the distance from the spinous processes to the lateral heart border is more than 5 centimeters, then we say it is right atrial enlargement. And finally, the left atrium, if it enlarges, it will cause a bulge in the middle part of the left heart border, and we'll see a case. Yes, this case beautifully shows the left atrial enlargement. See, there is a bulge in the region of the left atrial appendage, and when the left atrium grows superiorly, it pushes up the left main bronchus and leading to widening of this subcarinal angle. And another sign is this double heart border on the right side. So these three are the main signs of left atrial enlargement. Then finally, next, coming to the shape of the heart, there are certain named signs for abnormal heart shapes in certain specific disease conditions. For example, this is the famous boot-shaped heart. Cardiothoracic ratio is increased, apex is pointing upwards, RV type of cardiomegaly, and there is this depression or increased concavity in the region of the pulmonary conus. So this is boot-shaped heart or coherent SEBO seen in tetralogy of Fallot. Another named condition, the snowman heart or the figure of 8 appearance, because of this massive enlargement of the superior mediastinum. So this is seen in supracardiac TAP VC. We'll see CT also of all these cases. And another case, if we see, there is a LV type of cardiomegaly with a narrow vascular pedicle. This is the egg on side appearance seen in transposition of great arteries. Then after the cardiac silhouette, we come to the aorta. We have to comment about the size of the aortic knuckle also. There can be enlargement in the size of aortic knuckle, for example, in cases of bicuspid aortic valve because of post-stenotic dilatation, or it can be narrowed also, for example, in cases of hypoplastic aortic arch. Then we have to comment about the position of the aortic knuckle. Normally it is on the left side. If it is on the right side, you have to comment about it because that can be associated with congenital heart diseases, most commonly being TOF, tetralogy of Fallot, and also about the shape of the aortic knuckle. For example, you can see figure of 3 appearance in cases of coarctation of aorta. And finally, commenting about the pulmonary vascularity, the main pulmonary artery, after arising from the right atrium, it divides into right and left branches, which further divide into ascending and descending branches. So this is the descending branch of right pulmonary artery. Whenever there is increased flow to the pulmonary artery or pulmonary artery hypertension, there is dilatation of these central pulmonary arteries. So the measurement that they have given is if this descending branch of the right pulmonary artery becomes wider than 16 millimeters in males or 15 millimeters in females, then we say there is pulmonary artery hypertension. Or even if you don't measure the size, actually you can compare it with the caliber of the trachea on a frontal chest radiograph. If this artery is wider than trachea, we say it is definitely dilated. uh, and then there are multiple branches along the bronchi with gradual tapering towards the periphery, and there's a craniocaudal gradient as well. Because of gravity, there is less vascularity seen in the apices as compared to the bases. And uh, yeah, and actually, we have to comment whether there is pulmonary plethora, that is increased vascularity in the lung fields, or there is pulmonary oligemia, or reduced vascularity in the lung fields. So the increased vascularity can either be because of increased arterial blood flow, for example, is in cases of left to right shunt cases, or there can be increased vascularity because of decreased venous return, right? In cases of decreased venous return, we'll see signs of venous congestion. For example, first sign is the cephalization. That is, the upper lobe vessels will become as prominent as the lower lobe vessels, and as this condition progresses, there will be signs of pulmonary edema setting in. There will be a battering appearance or the curly lines. The curly B lines will be seen in the CP angles, and curly A lines will be seen in the perihilar location. So we have to comment about that. And yeah, this was a case of isolated pulmonary main pulmonary artery aneurysm. You see there is a prominent bulge in the region of the upper part of the left heart border. Another case, the cardiothoracic ratio is increased, the apex is pointing upwards. So we say this is RV type of cardiomegaly, and definitely there is pulmonary plethora, increased pulmonary vascularity. So this was a case of atrial septal defect leading to left to right shunt, and then increased pulmonary arterial blood flow. We'll see when we are studying ASD how the pre-tricuspid left to right shunts lead to right heart failure, and how the post tricuspid left to right shunts lead to left heart failure. For example, this case, if you see, there is a definitely cardiomegaly, but it is LV type here, and there's a prominent bulge in the region of the pulmonary conus, and the central pulmonary arteries are hugely dilated. So this was a case of ventricular septal defect with pulmonary artery hypertension, and the same was proved on the cath angio as well. If we see, the catheter here is in the left ventricle. The left ventricular cavity is getting opacified, and there is left to right shunt across this defect in the, this is the interventricular septum normal, this is the defect, and this is RV cavity that is getting filled from the LV. So this is VSD with PH. And finally, commenting about the bony cage, because cardiac anomalies can be associated with vertebral anomalies as well. So we have to look for those. And also, for example, in cases of Down syndrome, which is commonly associated with endocardial cushion defects, we'll have 11 pair of ribs rather than normal 12 pairs. And another thing that we have to look for is this rib notching. uh, I hope it is clear to everyone. There is a notching on the inferior surface of the third to eighth ribs in this case on both the sides. This was a case of coarctation of aorta. Because of multiple collateral channels, this leads to rib notching on the inferior surface. Okay, so after the warm up with the conventional radiograph, we'll come to the cross-sectional imaging, that is the CT and MR. Uh, I'll just run a case of CT angio, cardiac CT. These are axial sections, and I'll give you 2 minutes. Please study this case, and whatever information you can draw from this case, can you please write in one line in the chat box? I'll run the case again. Okay. So this is the impression that we gave for this case, SDS with AV concordance, with VA concordance, and with no structural cardiac abnormality. If this all sounds very complex to you, I assure you that at the end of today's session, you'll be able to formulate a report like this, and we'll see how. So first of all, we'll study the anatomy, the normal cardiac anatomy on this case only. So this is the we'll proceed in the direction of the blood flow. So the systemic veins coming to the right atrium, then to the right ventricle, then pulmonary arteries, then pulmonary veins to left atrium, left ventricle, and the systemic, that is the aorta. So we'll study all the chambers in that order. This is the superior vena cava draining into the right atrium. This is the coronary sinus also draining into the right atrium, and the IVC, three main tributaries of the right atrium. Now, how do we identify the morphological right atrium? Uh, this you see, it is the right atrial appendage, which is broad based and triangular in shape, and there are multiple filling defects within the right atrial appendage. These are the pectinate muscles, and this if you can make out, this is the crista terminalis, which is the junction between the right atrium main cavity and the right atrial appendage. This is a muscular ridge projecting into the lumen at the junction between right atrium and its appendage, and it causes a depression on the outer surface of the heart, which is known as sulcus terminalis. So for right atrium, please remember these points. These are important for the morphological identification of right atrium. Broad-based triangular appendage with filling defects with crista terminalis and the three main tributaries. Then coming to the right ventricle. This is the right ventricular cavity and connected to right atrium by the tricuspid valve. This, if you see, is the moderator band, which is a muscular band containing the right bundle branch, and it is connecting the septal wall to the free wall of right ventricle. This is the moderator band, which is the main identifier for the right ventricle. Other identifier is the atrioventricular valve, that is the tricuspid valve of the right ventricle, is located more towards the atrium, more towards the apex of the heart as compared to the atrioventricular valve of the left ventricle. And this distance is known as the offset. Okay, so that is the second identifier for the right ventricle. And what is the third identifier, which is the most important? That is the conus. I'll show you in other sections also. This is the muscular conus. So whichever artery arises from the right ventricle, it has a muscular tube below the origin of that artery. And it is called conus or infundibulum. And most important identifier for the right ventricle, because normally the pulmonary artery arises from the right ventricle, so we see a subpulmonic conus. But if the aorta arises from the right ventricle, then will see a subaortic conus. So these are the three main identifiers for the right ventricle. Then this is the pulmonary artery, we all know, bifurcating into right and left. Then coming to the pulmonary veins. These are the pulmonary veins draining into the left atrium. Two on either side. And for the morphological identification of the left atrium, this is the long tubular appendage of the left atrium with no filling defects. So we identify the atria by their appendage. Then this is the mitral valve, then the left ventricle with a smooth surface of the septal wall. There is no moderator band on the left side. So from these sections, we can get this much information. These are actually, this is what is, these are axial sections. So these are the body axis imaging, which include axial, coronal, and sagittal. But as we all know, the heart does not lie in the in these body axes, right? The apex of the heart is pointing down and out towards the left side. So we need certain specific axes for the heart, and they are called cardiac axis. The body axis planes, axial, coronal, and sagittal, and these are the cardiac axis. The four-chamber view, horizontal long axis, three-chamber vertical long axis, two-chamber, five-chamber short axis. We theoretically these are, but it is very important to know how to make these axes from your 3D MPR. So I'll just take you to a DICOM case, and I'll demonstrate how we make these cardiac axes on the 3D MPR. So I have opened the case. These are axial sections. Now we have the 3D MPR. So these are the body axis images, the axial, coronal, and sagittal. These are good for studying the overall morphology of the heart and also the pericardium. But to look for the specific defects in each of the chambers, we need cardiac axis. How we make those cardiac axis? Please see these steps very carefully. First, First step is to locate the mitral valve on the axial images, and we place the crosshair on the mitral valve, and we rotate the blue axis to point towards the apex of the heart. And now this image has converted into the two chamber view or the vertical long axis view. On these sections, we see the left atrium, the mitral valve, and the left ventricle. So we can comment about the morphology of all these three structures on these images. And also, if we take cine loops on the two chamber view or the vertical long axis view, we can also study the function of the mitral valve to diagnose mitral stenosis or mitral regurgitation. After that, the next step is to locate the mitral valve on the vertical long axis view and place the crosshair at the center of the mitral valve. And then we'll rotate the purple axis so that it points towards the apex of the heart, like this. And now our first image has converted into what is known as the short axis view. These are the short axis images which show the left ventricle and the right ventricle in cross section. So what all information can we gather from the short axis images? We can calculate the volume of the cavity of the left ventricle in end diastolic phase, in systolic phase, and we can calculate their difference to get the stroke volume. And stroke volume multiplied by heart rate will give us the cardiac output, and stroke volume divided by the end diastolic volume into 100 will give us the ejection fraction. So all these functional calculations we can do on the short axis images. And what else? We can calculate the wall thickness of the left ventricle. uh, we know that normally in the systole there is contraction of the heart, which leads to thickening of the wall of the left atrium. And if this thickness is more than 15 millimeters in end diastolic phase, then you can diagnose hypertrophic cardiomyopathy. Or if there is thinning, focal thinning, for example in this case here, then you can diagnose cases of myocardial infarction. This is about the still images. But if you have the cine loops on the short axis view, you can actually see the contractility of the heart. Then you can comment about global dyskinesia or hypokinesia or even hyperkinesia. Or you can comment about focal wall motion abnormalities also. And then coming to the right ventricle, normally the left ventricle is a rounded cavity, and the right ventricle is a concentric shape narrow cavity wrapping around the left ventricle. And you can also diagnose cases of RV enlargement in this short axis view, which will lead to straightening of this interventricular septum. Also, if you notice, there are two papillary muscles in the left ventricle. These are the anterior and the posterior papillary muscles. While on the right side, there are three: anterior, posterior, and septal. So that is also a difference between the morphology of the right and left ventricle. So after evaluating the short axis images, what we do, we place the crosshair at the mitral valve again, and we rotate the purple axis so that it points towards the center of the tricuspid valve. And now what we get is a four-chamber view. This is the four-chamber view, which nicely shows the morphology of all the four chambers of the heart, the interatrial septum and the interventricular septum. And if we take the cine loops in this section, we'll see the functioning of the tricuspid as well as the mitral valve. And if we scroll cranially from the four-chamber view, we'll get the five-chamber view, as we'll just see. Four-chamber view, by the way, is also known as the horizontal long axis view. And now this is the five-chamber view, which apart from the four chambers shows us the LVOT and the aortic valve. This is the five-chamber view. And finally, coming back to the short axis, we'll place the crosshair again at the center of the mitral valve and rotate the blue axis towards the LVOT to get this three-chamber view. This is the three-chamber view showing the left atrium, mitral valve, left ventricle, aortic valve, and the root of aorta. And if you these are the two leaflets, the posterior leaflet of the mitral valve and anterior leaflet of the mitral valve. And if you see, there is a continuity. Where the point where the anterior leaflet of the mitral valve ends is exactly where the aortic valve leaflets begin. So we say there is a fibrous continuity between the aorta and the mitral valve. This is known as fibrous aortomitral continuity, which is a identifier of the left atrium. If in cases of TGA, for example, if the pulmonary artery arises from the left ventricle, then we'll see a fibrous continuity between the mitral valve and the pulmonary valve. Okay, remember, there is no conus in the left ventricle. There is no conus, there is fibrous continuity. So that is about the cardiac axis. We have seen how we make all these five cardiac axes using the 3D MPRs. And yes, coming back to our sample report, now we learn how we form this report. So what I want you to see every case of structural cardiac disease as a fill in the blanks puzzle. Okay, so we have all done fill in the blanks back at school, right? So these are six blanks. So every cardiac case is a six blank puzzle, full stop. We just have to learn how to fill these six blanks. So just I'll take 1 second. This is the last section that we saw, the three-chamber view, and this is the fibrous continuity that I was talking about, seen in the left ventricle. And this is the right ventricle with the pulmonary artery arising from it. And this is the tricuspid valve. You see, there's a huge distance between the tricuspid valve and the pulmonary valve, while the mitral and aortic are in continuity. And this muscular ridge that is separating the tricuspid from pulmonary valve, this is known as the conus or the infundibulum, which is a very important identifier for the right ventricle. Okay, so this, coming back to the six blank puzzle, this segmental approach of evaluation of structural cardiac diseases was given by Dr. Van Praag, and this method of writing this report is known as the Van Praag notation. So what exactly is this segmental approach? They say that the heart can be divided into three major segments. That is the atrial segment, ventricles, and the great arteries. And we'll study these three segments one by one. And in step 4, we'll study the connection between the atria and the ventricles. In the step 5, we'll study the connection between ventricles and the great vessels. And finally, in the step 6, we'll look for specific structural defects. So this is the segmental approach that I was talking about, the atrial situs, ventricular situs or topology, situs or orientation of the great vessels, then AV connections, VA connections, and then finally associated malformations. So first step is the atrial or the visceral situs. So we have three options for this: situs, solitus, inversus, ambiguous. By this, we mean that if the right atrium is on the right side, it is situs solitus for the atria. If the right atrium is on the left side, it is inversus. And if you cannot say which is the right, which is the left, meaning that both the atria look like the morphological right atrium or both the atria look like the morphological left atrium, then we say it is situs ambiguous. So we have seen the normal anatomy, how to identify the morphological right atrium and the morphological left atrium. In very complex cases, it is not always possible to identify the morphology of the atria. For that, we use the rule of veno-atrial concordance or viscero-atrial concordance, which states that if the IVC is on the right side, we can assume that the right atrium is also on the right side. So it is important to look for the upper abdominal sections also to make sure that the liver is on right, the stomach and spleen are on left. So the visceral situs is normal. It suggests that the right atrium is on the right side. Also, the bronchial situs, we have to evaluate the trilobar lung on the right side, bilobar on the left side, early branching of the right bronchus, eparterial, hyparterial left bronchus, and all those things. If the bronchial and the visceral situs is normal, you can assume that the atrial situs is also normal because of the rule of viscero-atrial concordance. This we have already studied. Okay, so we are done with the first step, that is atrial situs. For that, we have three options: S, I, A, solitus, inversus, or ambiguous. The second step, that is the ventricular situs or the orientation of the ventricular loop. What does that mean? In the embryological phase, when the heart was developing, to begin with, the heart was a hollow tube like this. And then there was looping or twisting of this heart tube, which placed the morphological right ventricle on the right side and morphological left ventricle on the left side. So this is known as the dextro looping. And if this looping happens on the opposite side, it is known as levo looping. So we can conclude that if the right ventricle is on the right side, we'll say it is dextro looping or D looping. If the right ventricle is on the left side, we'll say it is levo looping. So very simple. What we have to do, we just have to identify the ventricles. If the right ventricle is on the right side, we say D looping. Right ventricle, morphological right ventricle on the left side, we say it is L looping. And how do we identify the ventricles? We have already studied the moderator band, the conus or the infundibulum, and on the left side, the fibrous continuity and smooth septal surface. So for step number 2, we have two options, dextro and levo. But again, in very complex cases, it is not always possible to identify the morphology of the ventricles. For that, we use the loop rule. This makes the job very easy. The loop rule states that if the aortic valve is on the right side, you can assume that the right ventricle is on the right side. And we'll just see how. So for the second step, we are done. The ventricular situs, two options, D or L for dextro or levo. We'll come to the loop rule. Yes, the step 3 is orientation of the great vessels or the situs of the great vessels. The red circle here represents the pulmonary artery and the valve of the pulmonary artery, and blue circle here represents the valve of the pulmonary artery. Okay, so in the embryological phase, the relation of these two was such that the aorta was anterior and pulmonary artery was posterior. Then what happened? There was looping of the heart tube, the hollow tube that we just saw for the embryological heart. There was looping or twisting of the tube, and that looping places the right ventricle on the right side, and it also causes rotation of these great arteries such that the aorta comes to lie on the right side and the pulmonary artery comes to lie on the left side. So there's a 90-degree twist towards the right side. This is D loop. So you see, when there was looping, two things happened. The right ventricle came to the right side and the aorta came to the right side of pulmonary artery. So that is the basis of the loop rule. If the aorta is on right, the RV has to be on the right. And in opposite cases, if the twisting happens to the opposite side, means L looping happens, then the right ventricle goes to the left side, and also the 90-degree twist of the great arteries also happens in the opposite direction. So the aorta comes on the left side. So this is known as D looping or L looping. Okay. And to begin with, the conus, the infundibular conus, the muscular conus that we talked about, it is below both the arteries, the aorta as well as the pulmonary artery. And we know that in adults, the conus has to be below the pulmonary artery only normally, because that arises from the right ventricle. So what happens? The conus below the aorta, it gets absorbed, and the conus below the pulmonary artery, it grows. Okay, so it further pushes the pulmonary artery anteriorly, and the final condition that occurs is this: the pulmonary artery is anterior and to the left, and aorta is posterior and to the right. Okay, so in effect, there is a total 150-degree rotation, 90-degree because of looping of the heart tube, and further 60-degree because of the growth of the pulmonary conus, which pushes it anteriorly. And if, again coming back to the L loop, in this condition, if now the subaortic conus will resorb and the subpulmonic conus will grow, then the pulmonary artery will be pushed anteriorly again, but now it will be anterior and to the right, and aorta will be posterior and to the left. So this is known as the mirror image. See, this is the normal relationship, and this is exactly the mirror image. So we say this is normally related great arteries, and this is inverted but still normally related. Why? Because aorta is posterior. Just remember that the aorta has to be posterior to the pulmonary artery. If posterior and to the right, it is normal related. If posterior and to the left, it is mirror image or the inverted relation. And uh, now suppose the pulmonary artery does not arise from the RV only. The aorta arises from the RV. So now what will happen? The looping of the heart will occur normally, the 90-degree rotation will occur, but now the subpulmonic conus will resorb and the subaortic conus will grow. So the aorta will be pushed anteriorly and resulting in this condition, which is known as DTGA. Why TGA? Transposition of great arteries, because aorta is anteriorly, and D because it is on the right side. I know this is slightly complicated, but please focus. Whichever artery is arising from the right ventricle will be anterior because it has a conus below it which pushes it anteriorly. So normally pulmonary artery is arising from the right ventricle, so that will be anterior. And in TGA or transposition of great arteries, aorta rises from right ventricle, so that will be anterior. So now just we have to see whether it is on the right side or on the left side. If aorta is anterior and to the right, it is DTGA or dextro-TGA. And if aorta is anterior and to the left, it is LTGA or levo-TGA. Now suppose that there are no two ventricles, there is just one ventricle, univentricular heart. Suppose that that single ventricle is the right ventricle, and both the arteries are arising from the right ventricle only. So both will have a conus below them. So both will be pushed anteriorly, and again, and after the 90-degree cardiac looping, both will come to lie side by side. So this is known as malposition of great arteries. Both are lying side by side in cases of univentricular heart. If and now again, if both are lying side by side with aorta on the right, this will become DMGA, that is dextro malposition of great arteries. And both are lying side by side with aorta on the left, this will become LMGA, or levo malposition of great arteries. So for step 3, we have all these options: the solitus, inversus or the mirror image, and TGA, DTGA, LTGA, and MGA, DMGA, LMGA. So this is the most versatile section, I tell you, because it fills both our puzzles, the second also and the third also. Why? Because aorta is on the right side, so because of the loop rule, the right ventricle has to be on the right side, which, so we can say that it is D type of ventricular topology or ventricular looping. And also because the aorta is posterior and to the right, we say the great arteries are also normally related. So both the second as well as the third steps are done. Again, stressing about the conus, because this is very important. The artery that arises from the right ventricle will have the conus. So subpulmonic conus is normal. Subaortic conus is seen in cases of TGA when aorta rises from the right ventricle. Bilateral conus means both the arteries are arising from the right ventricle, and bilaterally absent conus means none of the arteries is arising from the right ventricle. Both are arising from the left ventricle. So for step 3, these are all the options. Okay, we are done with the 3 steps. Now coming to the atrioventricular connections. So RA to RV, RA to RV, LA to LV, concordant AV connections. RA to LV, LA to RV, disconcordant. Ambiguous means both the sides look like right side, or both the sides look like morphological left side. So ambiguous. Double inlet, or this is seen in cases of univentricular heart. Again, both the atria are draining into a single cavity, that in a univentricular heart, so that is a double inlet, and the other ventricle is a rudimentary cavity lying at the side with no connection with any of the atrial cavities, so absent connection. So these are all the options for the step 4, that is the AV connections. uh, Finally, the step 5, that is the ventriculo-arterial connections. Uh, what happens in the embryonic phase? There is a truncus arteriosus, which separates, leading to formation of aorta and pulmonary artery. Now, if supposing this separation does not happen and the common trunk persists, that is known as persistent truncus arteriosus. That is one possibility for the ventricular-arterial connections. Other possibility, what normally happens, LV to aorta, RV to pulmonary artery. So concordant. LV to pulmonary artery, RV to aorta is discordant, as in cases of TGA. Double outlet right ventricle, both arising from right ventricle. Double outlet left ventricle, both great arteries arising from the left ventricle. So these are all the options for step 5. Okay. And finally, the 6th step is to study all these morphology in detail to look for the specific defects affecting the cardiac chamber or affecting the interatrial septum, for example, ASD, interventricular septum, VSD, or any particular malformations in the outflow tracts or the great vessels. We'll study each of these in detail. So coming back to the first case that we saw. Now we'll approach this case by this segmental approach. So our step 1 was to identify the atrial situs. Either we look for the appendages. This is broad based triangular appendage with filling defect. This is right atrium on the right side, so we say atrial situs is soletus. Or we can use the rule of veno-atrial or viscero-atrial concordance. The IVC is on right, so we say the RA has to be on the right side. So step 1 done. Step 2 is the ventricular situs. We see this is the moderator band, so this is RV, this is smooth septal wall, so this is LV. So RV on right makes this a D loop, D type of ventricular topology. Step 3 is relationship of the great arteries. So we go to the origin of the great arteries. Yes, this is the pulmonary artery bifurcating. Come to the level of the valve. Okay, this is pulmonary valve. This is the level of the aortic valve. So aorta is posterior and to the right of the pulmonary artery. So this is normally related great arteries. Okay, step 3 steps done. Now step 4 is AV connections. We have concluded that this is the right atrium because of the pectinate muscles and all those things. And we have concluded that this is the right ventricle because of the moderator band. So the RA into RV and LA into LV. So AV connections are concordant. Step 5 is VA connections, the ventricular arterial. So this is the aorta arising from the left ventricle, and this is the pulmonary artery. Go back to its origin, arising from the right ventricle with this subpulmonic conus. So the VA connections are also concordant. And then finally we look for specific defects in the interatrial septum, interventricular septum, great arteries, all the chambers. So there are none for now. So the 6-step approach, situs solitus with levocardia, because the apex is pointing towards the left side. Yes. The apex of the heart is pointing towards the left side, the base apex axis. We conclude the 6-step approach, situs solitus with levocardia. Step 1, D loop ventricle topology because RV is on the right side. Normally related great arteries because aorta is posterior and to the right of pulmonary artery. AV concordance with VA concordance with no structural cardiac abnormality. This is the impression of your report for that patient. I have a lot of DICOM cases, but I think in the interest of time, I'll stop here. And maybe next time we can discuss the cases as well as the individual malformation affecting each of the components. Over to Dr. Amit.
Yeah, ma'am. Thank you, ma'am.
Hello.
Hello.
Thank you, ma'am. So I'm really thankful. I think it was a very beautiful depiction of, starting from the plain X-rays to, build up a familiarity and then going on to cross-sectional images. It was a really useful session. And, rest of the cases, maybe we can take where we discuss these cases one by one in a DICOM session where we can take up 2-3 cases and then more detailed discussion can be done, and the students will also get some time to apply their own knowledge, so we can share these cases with them prior to the discussion so that they get maximum benefit.
Okay.
So already we are seeing a lot of good feedback on the chat box and waiting for the next session. Truly we are also waiting. So thank you once again, and looking